Dr. Rapezzi, Franco, and Jacopo, thank you for this invitation. And it's really nice to see the room still with many people, and I think this is really your merit. And well, my task is to talk about children cardiomyopathies, and in some way, I have to say that it is a difficult task. I don't have a formula, of course, for diagnosis in children, but what we can try to understand is why childhood cardiomyopathies are different from adulthood. And well, here there is a list of potential reasons, and the first clear reason is of course, we don't have a classification. I would say yet. It's an hope. But we probably have a lot in adult, probably more than we need. And on the other hand, we are trying to get some data, and I think in the next years we are going to have data in adult cardiomyopathy from the registries, but we have a lot of data in children coming from two main registries, one from American contributors and the other from Australia. And we learn a lot from this registry, and we think we probably need to have our own experience, and we really proposed our European experience recently that will be an associated project between the ESC and the European Society of Pediatric Cardiology, and we are really excited to say that phase 1 will start really soon. So what we really learn from this registry is that etiology is different, and etiology is really important because we know that we have a lot of metabolic disorders, syndromes, and neuromuscular disorders that in some way are part of childhood cardiomyopathies, and that they are really specific disorders, and they can have a different and sometimes worse outcome, like in Occam, as showed by Colin and co-workers. We know that metabolic disorders and malformation syndrome may have really a bad outcome, and it's the same for neuromuscular disorders in DCM, as shown by Tobin. But the main thing is we have etiology, but we can have tailored treatment, and this is in some way our main aim. Diagnosis can result in some specific treatment, like in storage disorders, but even in decision. For example, we know that there are conditions like Danon disease where we need to think about transplantation as early as possible, while in other conditions like mitochondrial or for instance, mucosal polysaccharidosis, we really need to think if transplantation is indicated. So, the main question, diagnosis. Again, there is no formula, but we can think about a step-by-step approach, as the title says. And the first approach is the cardiologist. Of course, as cardiologists, what we see, what we normally see is imaging, is echocardiography. And when we see a left ventricular hypertrophy, the first question is it Occam? And the second question should be, what kind of Occam we are facing? And well, of course, it will be really nice to have special glasses and see what is under this left ventricular hypertrophy, but we cannot do that. We are trying with, in some way, with new technologies and with MRI to facilitate the diagnosis, but we still are not there. So what we can say is that, and what has been proposed by Claudio Rapezzi, it's a step-by-step approach, the so-called red flag approach. There is a multi-parametric approach to diagnosis, and I think it's valid in children and in adults as well. And this approach should start with family evaluation, going to clinical presentation, instrument evaluation, and finally imaging. Well, what we usually do is the other way around, but it doesn't matter. The main thing is to cover all these levels and try to look for red flags, for hallmarks of the disease in each of these steps. So let's try to start a possible diagnosis. Of course, there are three main points. I would say age, inheritance, and clinical presentation. In some way, we can think about also geographical origin of the patient for some specific condition, but age is really important because we know that the DCM is completely a different disease in neonates, in children, and in adolescency. And when we see a case like that, a 2-day male with dilated cardiomyopathy, of course we need to think about myocarditis. But well, we also need to look for the aorta because this can be a phenocopy of a dilated cardiomyopathy, and this is a condition that should be treated as soon as possible in neonates. And again, another case, 1 month, dilated cardiomyopathy. Let's look for coronary arteries. This is another phenocopy of the disease we should look for, because we should operate a condition, an anomalous origin of the coronary arteries. And it's the same for OCAM. If we have a neonate with the OCAM, we should think about, of course, we should exclude the maternal diabetes or the use of steroids. And in children with a concentric hypertrophy, like this case, of course we should exclude some phenocopies like obesity, hypertension, and physiological conditions like athletic training. Well, let's say that the two cases we have seen before, in these two cases we ask for family history, and we find a family history for cardiomyopathies, or early death in infants, or sudden death. Well, probably this is a different case. We are now introducing another step, the family history, and in this case, when we have a clear family history, we need to think about familial disease or genocopies of the disease. And we can have red flags in or specific inheritance, like matrilinear inheritance in mitochondrial disorders. But even if we lack a clear inheritance, like for autosomic recessive disorders, let's ask for consanguinity, because we probably are facing, we may find some metabolic disorder with autosomic recessive inheritance. And well, of course we can talk about clinical presentation for hours, but I think we should try to concentrate on some specific condition, like muscle abnormalities, organ of sense abnormalities, dysmorphisms, and encephalopathy. These are typical presentation in association with cardiomyopathies in children. And, well, there are some conditions that are really typical. If you see a neonate with a severe hypotonia, the so-called floppy baby, in association with cardiomyopathy, of course, you have to exclude some storage disorder like POM disease. But and of course it's treatable, but on the other hand, you should also think about the mitochondrial condition. If skeletal myopathy comes later in life, what you should probably ask for is, what is the type of exercise that provokes symptoms, and are there associated triggering factors? Because you can have different clinical presentation, like exercise intolerance, even for mild activities, that is typical of mitochondrial disorders, or cramps and myoglobinuria that are typical of glycogenosis and fatty acid disorders. And in this latter condition, you can have some stressors like fever or fasting that can in some way provoke the symptomatology. And, well, of course, there are some organs of sense abnormalities that can be associated with genocopies of the disease, like retinitis pigmentosa that is typical in mitochondrial or even in Danon, or sensory neural deafness that, as you can see, is associated to a number of conditions like Leber syndrome or Alström syndrome, or in mitochondrial disorder, in a typical syndrome that is called MELAS, in association with diabetes and generally hypertrophic cardiomyopathy. And what is also important is to look the face of the patients, of course, and trying to find typical features like hypertelorism or ptosis, or even skin abnormalities like cafe au lait spots or multiple lentigens. Well, these are features of a number, of course, of Noonan syndrome, but of a number of associated disorders, the so-called family of neurocardiofacial cutaneous syndromes, that in some way they share a similar clinical presentation, but also the same molecular background, that is mutation in the RAS protein genes. And I think this pathway is fascinating. It's fascinating because genotype, phenotype, of course, in good hands, is possible. There are some dysmorphologists, like Cristina Di Gino in Rome, that are able to think about a face associated to a gene. Or we are getting data about the association specific gene with specific cardiomyopathy. We know that RAF1 is associated with a severe form of OCAM, while other genes like PTPN11 and SOS1 are associated generally with other congenital disorders like pulmonary stenosis. And also there is a new interest about specific therapies, but this probably is another story. Of course, the clinical investigation should consider ECG. ECG is really important. We can have red flags. For example, we know that AV blocks can be typical of neuromuscular disorders and Lamine-EC disease, or for example, right bundle branch block that is typical associated with Noonan syndrome, or the so common and well-reported short PR, with or without a clear delta wave, that is associated to a number of conditions like storage disorders, lysosomal disorders, but also mitochondrial diseases. Well, we really don't know, on the other hand, the specificity and sensitivity of these red flags. And in some way, I think we always need to consider the overall presentation of the patients. Of course, if you have a patient with OCAM and short PR, we should think about a number of disorders. But if you have red flags like hearing loss, exercise intolerance, and stroke-like episodes, well, we probably have this famous mutation associated to MELAS syndrome. But generally, it's not so easy. Well, one of the probably one of the most important messages for us, for the general cardiology, imaging is important, but is not all. Of course, we can have some clues for a phenotypic characterization of the disease, like, for example, the typical localized infrabasal akinesia associated to non-compaction in neuromuscular disorders, or even the biventricular hypertrophy and biventricular obstruction in Noonan syndrome and associated disorder. But this is something nice, but we need to have a clear and complete clinical picture. And I think the clinical investigation, I really enjoyed the first day, the presentation of by Alice Donati and Elisa Pasquini. I think here there is a really wide experience on diagnosis of metabolic disorder, and I think this is a really a black hole in children cardiomyopathies. And again, I don't have a formula to propose, but of course we probably need to consider some parameters like enzymes to exclude neuromuscular and metabolic disorders. We need to have an hemochrome in some way, and we probably need to exclude a presentation with hypoglycemia. We need a lot more, but let's start with this. And this is step one, if we want, starting with the presentation of the patient. And if we are really lucky, we can probably have a suspicion of diagnosis. And I think we always need step two, that is our network of specialists, like geneticists, clinical geneticists, expert in metabolic and neuromuscular condition, and well, in some way we need to exclude with a dysmorphologist a genetic syndrome. We need to exclude with an expert in neuromuscular evaluation, of course with other specific investigation in neuromuscular condition, and probably we need to exclude a metabolic condition in many of these cases. And this is probably the main step to have, if you are lucky again, to have a final diagnosis. We need to remember that more than half of the patients with childhood cardiomyopathies have an idiopathic cardiomyopathy, even after a complete evaluation. This is the probably most controversial step, that is the pathologist. As Lydia said before, of course, the diagnosis of myocarditis it's a anatomic, pathological diagnosis, and in some way confirmed with the molecular analysis to find the virus and the adjunct. We don't have much data in children, but what the guidelines, what we have so far, suggest in unexplained cardiomyopathy a 2A level C consideration for endomyocardial biopsy. But I mean, I think it's a lot related to the experience and to the culture of each center. And well, again, this is not a formula, it's just a suggestion. We probably need to consider a step one evaluation from the cardiologist, but the most important part is the network. And so we really need the help of specialists to reach the final diagnosis. And I just want to leave the message, but I'm not the only that is leaving this message, that cardiomyopathy, each cardiomyopathy is not one disease, but they are many diseases with different outcome and management. And this is true in childhood, but also in adult cardiomyopathies. Imaging is important, but is not all. And we really need a multi-parametric approach and a good network, because this is the most important part of our screening. And if you have a good network, we are more likely to get a final diagnosis. Thank you.
Yes, thank you. Congratulations. In one of the slides, you mentioned obesity as a potential differential diagnosis for phenocopy. So I'm just curious, do you really see hypertrophy or obesity cardiomyopathy in fat children? Is that a problem?
Okay. Thank you for this question. You know that in Campania is the region where obesity, the level of obesity, the frequency of obesity is higher in Europe and probably one of the 2-3 in the world. So we have probably bias with obesity. And in some way, we have an outpatient clinic looking at obesity. What we generally see in this patient is an increased left ventricular mass that is generally related to a concentric hypertrophy. You are not likely to see an asymmetrical left ventricular hypertrophy like, for instance, in an infant of a diabetic mother. Of course, the age is different, the presentation, but an infant of diabetic mother is a big baby, so is an infantile obesity. And the other thing we normally say is a really early abnormality of diastolic function that sometimes you can see with the standard echocardiography or with the Doppler tissue imaging. And in some way, there is probably a correlation with the evolution later in life of a potential cardiomyopathy. But I think we need to understand a lot about obesity and diabetic cardiomyopathy. And so it's probably a task for the future.
Beautiful presentation. I think it would deserve, for sure, a longer time. But I think it's really very important, to be aware of this. Also, to be aware of the fact that we are facing more and more children, coming from other countries, from Africa, from China. So, and we have to understand whether this is also, if they have similar cardiomyopathies as we see in Caucasian. But one major point, beyond the fact that I agree with you that there must be some referral center, we should have a registry, so I fully agree with all this, is about syndromic. What we are not used as cardiologists is to understand where there is a cardiofascial syndrome. We all, after all, figure out unless there is really, syndromic, trisomy. Usually, we don't really care much about that. Is there a kind of, on Google image or on Ask Cardiology registry or wherever, it may be something that, may be of help to all cardiologists to understand better, these cardiofascial syndromes that can direct you towards the syndromics. For instance, apparently, they seem to have, if you agree, and this is might be my question also, an increased risk of sudden death. So, we have to take into account this risk, but we have also to recognize that there will be for sure sarcomeric negative, and then, of course, we are going to have a better diagnosis.
Thank you for this question. I think you pointed out a lot of issues, because first is geographical. Geographical is important because, of course, you can have some typical, like Chagas cardiomyopathy or Loeffler disease, and that can be typical of some regions. The second point is presentation. Many of the features we see, particularly in this morphology, are age-related. So sometimes these morphologists ask for a picture of a photo of the neonate or the young children, because when they grow, the face can be even normal. So this is really a problem in a way for adult cardiologists. That's why we need probably a new way of thinking. And the first thing is look at the face, look at the thorax, and look at the skin in some way. And second, if you think that all is normal, but you think that something is funny, don't stop. Just ask to an expert. This is my point of view. I don't know about the website. I don't know about there is a program that is called I think the Oxford database that geneticists expert in syndrome use generally, and you can put some features like, for instance, cardiomyopathy plus skin abnormalities, and you can get some possibilities. I'm not sure if you have, I think you have pictures as well.
Enjoyed your presentation. My question relates to treatment of very advanced cases. And as you said, from the registries, both in Australia and the US, and now coming in Europe, the prognosis of dilated cardiomyopathy in infants and children is much worse than in adults. And therefore, we will never find enough hearts, even worse than in adults. And the comment or question I'm having is that the question of reversibility. Now, we have had this case which was reported in the Lancet, whereby she was moribund as an infant, but she had heterotopic transplantation, and 2 years later, her own heart recovered. And we left the heterotopic for another 8 years, but she developed lymphoproliferative disease, malignant. We took the donor heart out, stopped immunosuppression, and she is very well. So the question to you and is the question of reversibility. Now people say, how are you going to determine who's reversible and who's not? But maybe that's coming with meetings like that with Franco and Jacopo.
Thank you for your question, Professor Jakub. I think this is really an important point. And yesterday you pointed out how it is important to consider early aggressive therapy, even with the LVAD in some condition. And I think in some way we need to help transplant people. We need to collaborate with them, because if we face a myocarditis, probably, and we think that it is reversible, we should be as much as aggressive as possible with medical or non-medical therapies. If we think that we are facing a metabolic disorder, like, for example, a carnitine disorder, well, we need to perform the diagnosis, because this is in some way reversible. Or if we have a POM disease, well, we have a therapy. Of course, long-term data are controversial, but still we have a therapy. So in some way, when we think that we have a tailored treatment, we should make diagnosis and we should choose the right treatment.
Thank you.